Right now, the exact same molecule being used to plump lips and sculpt cheekbones in high-end dermatology clinics is quietly revolutionizing something completely different.
Oh, absolutely. It's revolutionizing how we treat one of the most painful yet unspoken side effects of menopause.
Yeah, and we are talking about taking hyaluronic acid, stripping away its cosmetic reputation, and utilizing it as a foundational tool in women's intimate health.
It really is a fundamental paradigm shift in gynecological care. We are moving away from viewing these compounds as just aesthetic enhancements,
Right.
and we're finally recognizing them as highly engineered biostimulators,
Yeah.
capable of restoring degraded physiological function.
And that is exactly the mission for this deep dive. If you've been following the aesthetic medicine space, you are going to find this fascinating.
Definitely.
We have a stack of clinical case reports and medical guidelines to explore today, detailing exactly how clinicians are using injectable skin boosters, so cocktails of hyaluronic acid, calcium hydroxyapatite, and polynucleotides, as well as energy-based devices.
Yeah, and using them to treat vulvovaginal atrophy as non-hormonal alternatives.
Which is just wild to think about.
It's deeply necessary medical intervention. I mean, the goal here is restoring tissue integrity and mitigating the often debilitating symptoms that accompany the drastic hormonal shifts of perimenopause and postmenopause.
Right. So to understand the brilliance of these new interventions, we really need to map out the biological problem they're trying to solve first.
That makes sense.
Because as a woman approaches menopause, the sudden drop in estrogen and androgens triggers a systemic cascade. But the local impact on the genitourinary tract is uniquely severe, right?
It is. The clinical term for this is vulvovaginal atrophy, or VVA, which actually falls under the broader umbrella of genitourinary syndrome of menopause, or GSM.
Okay.
And the latest studies indicate this affects anywhere from 36% to 90% of perimenopausal and postmenopausal women.
Wow. That is a huge range, but even at the low end, that is a massive demographic.
Exactly. And physiologically, the withdrawal of estrogen basically deprives the tissue of its primary metabolic signal.
So without that signal, what actually happens?
Well, the production of glycogen plummets, the local microbiome shifts, and the structural components of the tissue simply degrade,
Just fall apart.
pretty much.
Hmm.
The adipose tissue, so the fat pads in the labia majora, diminishes significantly. Internally, the vaginal epithelium transitions from this robust, multi-layered, corrugated surface into a pale, ultra-thin, almost friable lining.
Okay, let's unpack this for a second. So it's like a sponge that has completely dried out.
That's a really good way to visualize it.
Right, like losing both its structural scaffolding and its ability to hold moisture at the exact same time.
Exactly. And because the tissue loses all of that, its scaffolding, its vascularity, its natural hydration, the downstream effects are entirely compounding,
I can imagine.
and they severely impact daily life. Because the epithelium becomes so fragile and dehydrated, patients experience persistent itching, profound dryness, and vestibular burning that occurs completely independent of any physical contact.
So it just constantly hurts.
Yes, and during sexual intercourse, this manifests as dyspareunia's severe pain, which frequently results in postcoital microlesions.
Which are basically microscopic tears, right?
Right, actual microscopic tears in the mucosal lining. And beyond that, the thinning of the surrounding genitourinary tissue frequently leads to dysuria, urinary urgency, and a marked increase in recurrent urinary tract infections.
Okay, so a very serious cascade of issues. But I have to ask, why not just take hormones and be done with it? Like, if the tissue is starving for estrogen, you just resupply the estrogen.
Well, you're not wrong. Topical vaginal estrogens remain the gold standard for moderate to severe VVA. They are highly efficacious at reversing that cellular starvation.
But there's a catch.
There is always a catch. Long-term continuous use presents clinical limitations. And more critically, there is a substantial demographic of patients for whom exogenous estrogen is strictly contraindicated.
Ah, right. We see this heavily emphasized in the oncology guidelines within our sources.
Exactly. Patients navigating hormone receptor-positive breast cancer or those with specific thrombotic conditions, they just cannot safely utilize local or systemic estrogen.
So for those patients, what does traditional medicine offer?
Historically, very little beyond basic inert lubricants and moisturizers.
Which just sit on the surface.
Right. Those products might temporarily reduce friction, but they do absolutely nothing to reverse the underlying tissue atrophy or stimulate cellular repair.
It leaves this massive, frustrating gap in clinical care for a highly vulnerable patient population.
Which perfectly sets the stage for the injectable solutions.
Yes. Clinicians are now turning to this process called biorevitalization.
Exactly. So instead of replacing the missing hormones, they are injecting a highly specific regenerative chemical matrix directly into the atrophied tissue.
We are bypassing the hormonal receptor pathway entirely.
Yes, and directly stimulating the local fibroblasts, the cells responsible for producing collagen, and the extracellular matrix using materials that mimic the body's own structural components.
Okay, let's look at a concrete clinical application of this from the sources. We have this primary case report detailing a 48-year-old perimenopausal woman.
Right.
Her diagnostic workup, pap smears, vaginal swabs, was entirely normal, but she was experiencing intense chronic dryness, burning, and those painful microlesions you mentioned.
A textbook presentation of severe symptomatic VVA.
Yeah, and the atrophy was so advanced that even the friction from just wearing regular underwear and panty liners caused severe irritation.
It really highlights how these structural deficits infiltrate every hour of a patient's daily routine. It's not just an intimacy issue.
Here's where it gets really interesting, though. To treat her, the clinical team utilized a layered biorevitalization approach, injecting a very specific multi-ingredient cocktail.
Yes, a highly engineered cocktail.
The primary component was PEGD cross-linked hyaluronic acid combined with calcium hydroxyapatite. I want to zero in on the chemistry here for a second, starting with that PEGD cross-linking.
Sure.
Because in standard cosmetic fillers, you often see BDD used to bind the HA molecules together so they don't break down immediately, right?
That's correct. BDDE is standard for facial aesthetics.
But PEGD, polyethylene glycol to glycidyl ether, creates a much more flexible, biocompatible polymer network.
Exactly. And if you are injecting into a dynamic, ultra-thin mucosal space like the vagina,
Okay.
rather than just resting it against a rigid cheekbone, that mechanical flexibility seems critical.
Because it has to move.
Right. The rheological properties, basically how the material flows and deforms under stress, are paramount in this anatomical region.
A rigid filler would be awful.
It would cause immense discomfort and unnatural tissue mechanics. So PEGD cross-linking yields an HA matrix that integrates seamlessly into the mucosal layers.
And then it expands.
Yeah, it expands to draw in massive amounts of water, which instantly addresses the severe dehydration while maintaining the pliability required for normal physiological movement.
Okay, so that handles the hydration and flexibility. Then we have the calcium hydroxyapatite, or CoHy.
Right.
And this isn't just a hydrating agent at all, is it? It behaves completely differently in the tissue.
Oh, completely differently.
Yeah.
KAA acts as a robust biostimulatory scaffold. When it's suspended within that flexible HA matrix, the microscopic calcium and phosphate microspheres provide immediate structural support.
But the real magic happens later, right?
Exactly. The true clinical value emerges over the following months. As the body's macrophages slowly begin to enzymatically degrade those microspheres, that controlled inflammatory breakdown sends powerful signals to the surrounding fibroblasts.
It's essentially tricking the tissue into an ongoing state of targeted repair.
That's a perfect way to phrase it. It forces the fibroblast to lay down fresh, dense type I and type III collagen in place of the dissolving cowid.
So it physically thickens and strengthens the atrophic vaginal wall from the inside out.
Long after the initial injectable material has metabolized, yes.
Okay, so we have hydration from the HA and architectural rescaffolding from the KA. But the formulation in the case report didn't stop there.
No, they also utilized a product heavily featuring polynucleotides, or PNs.
Products like Nugen, right?
Exactly. And polynucleotides elevate this from a simple structural intervention to a highly active metabolic therapy.
Because they are DNA fractions.
Yes, highly purified, high molecular weight DNA fractions. When introduced into the extracellular matrix, they bind to specific cell surface receptors, primarily the A2A adenosine receptors.
And triggering that receptor pathway effectively clears out localized free radicals, doesn't it?
It does. And it provides the fibroblast with an immediate, massive nucleotide pool for DNA synthesis and cellular proliferation.
So it dramatically accelerates the tissue's endogenous repair mechanisms.
It acts as a profound metabolic catalyst for the senescent cells within the atrophic tissue.
Wow. And this metabolic stimulation is further supported by the specific amino acid profile included in these injectables, right? Predominantly glycine and proline.
Yes.
I noticed they specifically highlight glycine and proline in the formulations. And considering those two amino acids make up the vast majority of the collagen triple helix, I imagine this isn't random.
Not random at all.
They're basically handing the stimulated fibroblasts the exact biochemical bricks required to assemble new collagen fibers.
You cannot demand increased collagen synthesis from a fibroblast without ensuring the local environment contains the requisite raw materials.
That makes total sense.
Supplying glycine and proline alongside the polynucleotides ensures the regenerative cascade isn't bottlenecked by nutritional deficits at the cellular level.
Brilliant. Now, there's one more ingredient that caught my eye in these biorevitalization cocktails. Mannitol.
Ah, yes.
It's a sugar alcohol, right? But in this specific biochemical environment, it seems to act almost like a sacrificial antioxidant.
That is an incredibly accurate way to view its function.
Huh.
See, the moment you introduce an exogenous, hydrating substance like hyaluronic acid into the body, you trigger an immediate immune response.
The body tries to fight it.
Exactly. The tissue's natural hyaluronidases, the enzymes that break down HA, and local oxidative free radicals immediately begin attacking the injected matrix.
So the mannitol intercepts that attack.
Yes, it offers itself up to the oxidative stress, effectively neutralizing the free radicals before they can degrade the hyaluronic acid.
Wow, so it extends the clinical lifespan of the hydration in the scaffold?
It shields the primary therapeutic agents, ensuring the HA and the CHA have sufficient time to integrate into the mucosa and trigger that long-term neocollagenesis.
It really emphasizes that this is not a cosmetic cover-up. It is a highly calculated, multi-stage biohack utilizing flexible polymers, metabolic catalysts, and sacrificial antioxidants to fundamentally reverse tissue degradation.
It's incredibly sophisticated.
But having the perfect regenerative cocktail in a syringe brings us to the immense logistical challenge of actually delivering it.
Right, the application.
Because the clinical guidelines are very strict about the methodology here. Specifically, there's this big debate in the sources between manual versus machine injection techniques.
Yes, and this is crucial. The utilization of automated multi-needle injection devices, often called mesoguns or machine skin boosters, has become incredibly popular in facial dermatology.
Because they're fast, right, and they offer uniform depth delivery.
Exactly. However, the consensus in the sources regarding vulvovaginal applications strongly discourages their use as a primary modality.
Why is that? Just because the intimate anatomy is dramatically more complex?
Complex, and in cases of severe VVA, hypersensitive to pain.
Oh, right.
An automated machine lacks tactile feedback. It operates on programmed depth and volume, completely blind to the variable tissue resistance of the vaginal wall.
So it doesn't know if it's hitting a thin spot or a thick spot.
Exactly.
Yeah.
Or the specific contour deficits of an atrophic labia majora. Furthermore, the extreme thinness of the mucosa in a menopausal patient means an automated multi-needle stamp can easily cause excessive, uncontrolled microtrauma.
Which exacerbates the very microlesions we are attempting to heal in the first place.
Exactly. So manual injection is mandated because it requires continuous, millisecond by millisecond clinical judgment.
The practitioner has to literally feel their way through it.
Right. They must constantly adjust the pressure, angle, and depth based on the immediate visual and tactile response of the tissue.
To understand what that manual technique actually entails, the sources detail the Desiril protocol and various multi-layer injection strategies.
Yes.
It starts with proper anesthesia, which is non-negotiable here, and then they utilize an 18-gauge cannula rather than a sharp hypodermic needle for the deeper tissue work.
Utilizing a blunt-tipped cannula is a critical safety measure.
Because of the blood vessels.
Exactly. The genitourinary area is highly vascularized. A sharp needle easily shears through those blood vessels, leading to significant hematomas and prolonged recovery.
Ouch.
Yeah. A blunt cannula, conversely, gently pushes the vascular structures aside as it navigates through the deep dermis and subcutaneous layers.
And the protocol specifies using a retrograde fan technique with that cannula to restore the volume of the labia majora.
Correct.
So the clinician advances the cannula to its full depth and then steadily injects the cross-linked HA matrix as they slowly withdraw it, right? Fanning it out in multiple directions from a single entry point.
It creates a smooth, highly integrated distribution of the product. It rebuilds the structural volume and contour of the labia majora evenly.
Which is important for protection, I assume.
Very. It provides a crucial physical cushion that protects the delicate internal structures from daily mechanical friction.
Okay, so after addressing the deep structural deficits, the protocol moves to the more superficial layers, the ultra-thin atrophic mucosa itself.
This is where it gets very precise.
Right, because the clinician places tiny microboluses of the product right beneath the surface. And this brings us to a highly specific detail regarding post-procedure outcomes, and I really want to focus on this.
Okay.
The guidelines explicitly state that clinicians will often inject the remaining product into the labium minora and the side of the vestibule, creating, and I quote, several small hives.
Yes.
Now, if you are injecting a viscous, water-drawing gel superficially into mucosal tissue that is already compromised and paper-thin, you are inevitably going to create transient micro-wheals. You're going to create localized papules and a distinctly puffy feeling in a highly sensitive area.
Yes, that is exactly what happens.
So how does a clinician actually manage that reality? How do you prevent the patient from experiencing immense anxiety about that outcome? Because that sounds terrifying if you aren't expecting it.
It does. But the creation of these superficial micro-wheals is an inescapable mechanical reality of biorevitalization in this area. Managing the patient's experience of it is actually a cornerstone of the clinical protocol.
Okay, so walk me through it.
First, we must address the sensory aspect. As the sources note, creating these hives is modestly painful, but it is rendered bearable through rigorous preemptive pain management.
The sources mention a specific 30-minute prep time, right?
Yes. Clinicians heavily rely on profound topical anesthesia before beginning the superficial injections.
Like what kind of anesthesia?
This typically involves a 2.5% lidocaine and prilocaine cream, or a highly concentrated 30% lidocaine galenic gel applied directly to the mucosa a full 30 minutes prior to the procedure.
Oh, wow. 30% is high.
It is, but it blunts the sharp pain of the localized tissue expansion when those microboluses are placed.
Okay, but the physical manifestation in TEMD, the micro-wheals and the puffiness that still remains after the anesthesia wears off.
Yes, it does. And this is where proactive patient education and the clinical strategy of watchful waiting become paramount.
Watchful waiting.
Right. Clinicians manage this primarily by setting rigid expectations before the syringe is ever prepared. The patient is explicitly informed that feeling brief, mild swelling, or palpating these transient micro-wheals is not a complication.
It's actually supposed to happen.
It is the exact, desired, normal post-treatment response. It indicates the HA and the polynucleotides have been successfully deposited into the superficial matrix and are actively beginning to draw in hydration.
Oh, okay. So they are reframing the swelling from a point of panic into a sign of efficacy.
Precisely.
The biohack is physically taking up space. So how long does the clinical protocol suggest this watchful waiting period lasts?
In the vast majority of cases, the product integrates smoothly into the surrounding tissue matrix, and the micro-wheals resolve spontaneously within 48 hours.
Just 2 days.
Yes. The localized puffiness subsides as the hydration equalizes across the mucosal plane.
And if it doesn't resolve in 48 hours, what then?
Well, the management protocol establishes a very firm follow-up boundary. The clinician instructs the patient that watchful waiting is only appropriate for a limited window. If the swelling or the presence of the papules persists beyond a single week,
Oh, wait. Okay.
or if it is at any point accompanied by severe escalating pain, abnormal heat, or unusual discharge, the patient must return for immediate clinical reassessment.
Because beyond that 1-week mark, you have to rule out infectious complications, right? Or localized inflammatory reactions or potential vascular compromise.
Exactly. But as long as it's just that initial transient puffiness, watchful waiting, grounded in thorough pre-procedure education, is the gold standard for managing these micro-wheals.
It requires immense trust between the practitioner and the patient.
It does. It relies on the knowledge that the temporary structural disruption is paving the way for long-term tissue regeneration.
That is fascinating. Okay, so if injectables represent a chemical approach like delivering the specific blueprints and bricks for regeneration directly into the tissue, the other major branch of non-hormonal treatment relies on physics.
Yes, energy-based devices.
Right. Specifically, utilizing devices like radio frequency and fractional CO2 lasers to address VVA. Because if injectables are dropping off construction materials, these devices rely on causing a highly controlled local crisis to force the body to manufacture its own materials.
That's a great summary. We are leveraging the principles of controlled thermal trauma.
So what does this all mean for patients? Let's start with radiofrequency or RF therapy.
With RF, clinicians use specialized devices, either monopolar or bipolar, to pass a targeted radiofrequency current directly through the vaginal tissue.
And the tissue itself acts as a resistor to that electrical current.
Exactly.
And basic physics tells us that resistance generates heat.
Yes. The clinical target is to utilize that tissue resistance to safely elevate the local dermal temperature to approximately 43 degrees Celsius.
And why 43 degrees?
At this precise thermal threshold, a very specific cellular response occurs.
This is where the biological cascade kicks in, right?
Right.
The heat essentially stresses the cells just enough to activate heat shock proteins.
Exactly. At 43 degrees, the existing collagen fibers undergo immediate localized contraction, which provides a slight temporary tightening effect.
Okay.
But more importantly, the thermal stress causes cellular proteins to begin denaturing slightly. To survive this thermal event, the cells rapidly upregulate the expression of heat shock proteins.
And these proteins act as molecular chaperones, right? I mean, their primary job is to refold the damaged proteins and stabilize the cell.
Right, but their activation also triggers a much larger alarm bell throughout the local tissue matrix.
It initiates an inflammatory cascade.
Yes, a controlled, localized inflammatory cascade. This aggressively signals the fibroblasts, dramatically upregulating procollagen mRNA expression.
So it tricks the body into perceiving a significant injury.
Exactly, prompting the fibroblast to flood the area with brand new, highly organized collagen and elastin fibers to essentially heal the thermal damage over the subsequent weeks and months.
It is an engineered survival response, just like a controlled microburn to force the body to remodel the house.
Very much so.
But that mechanism of action immediately raises a critical red flag for me.
I can guess what it is.
We have established that in cases of advanced VVA, the mucosal tissue is paper-thin, incredibly fragile, and already highly prone to tearing.
Yes.
Is it actually safe to intentionally induce thermal trauma to essentially create a micro burn on tissue that lacks any structural buffer?
This specific safety concern is the epicenter of a massive, ongoing debate within the gynecological and dermatological communities. And the data in our clinical sources is heavily polarized.
Let's look at the promising side first. RF hasn't been completely dismissed, right?
Not at all. Radiofrequency has demonstrated legitimate potential in highly controlled environments. Histological studies on animal models, specifically sheep and pigs, have shown that monopolar RF applicators successfully and safely increased local collagen production.
Okay.
It also improved vascularity and stimulated healthy fibroblast development when assessed 3 months post-treatment.
But translating animal histology into treating a highly symptomatic, atrophic human patient is a massive leap.
It is a leap. And when we look at the other major energy modality CO2 lasers, the safety profile becomes significantly more alarming.
Right. The controversy surrounding CO2 lasers is stark in the sources.
Very. Unlike RF, which heats the tissue via electroresistance, CO2 lasers aggressively ablate the surface tissue, basically vaporizing the water content within the cells to trigger that healing cascade.
Vaporizing the water in tissue that is already severely dehydrated.
Exactly. Because of the inherent fragility of atrophic tissue, the US FDA has issued explicit, severe warnings regarding the use of CO2 lasers for so-called vaginal rejuvenation.
And those warnings specifically cite serious, life-altering adverse events. We're talking severe burns, intractable pain, and permanent scarring.
Yes, inducing thermal trauma on a mucosal layer that is already decimated by estrogen loss can easily cross the line from a controlled crisis to profound, irreversible tissue damage.
And the most recent rigorous clinical data really reinforces that regulatory caution, doesn't it?
It does. The guidelines cite a comprehensive 2025 systematic review by Zurzan et al., which analyzed the broad spectrum of energy-based interventions for VVA.
And what did they find?
Their findings regarding CO2 laser therapy were highly sobering. The data indicates that laser therapy yields minimal to no significant differences in long-term clinical outcomes when compared directly to standard vaginal estrogen therapy.
Wow.
Or, even more tellingly, to sham treatments.
Wait, really? They compared it to a placebo laser treatment?
Yes.
And the actual laser failed to demonstrate a statistically significant superior benefit while still carrying the very real FDA-warned risks of burns and scarring.
Correct. The current overarching clinical consensus is that the evidence supporting ablative lasers for this specific condition is highly uncertain and limited.
When you lay the mechanics side by side, it perfectly illustrates why the clinical momentum is shifting so heavily toward biorevitalization. I mean, intradermal injections of HA and polynucleotides might require navigating needles and managing 48 hours of localized puffiness and those micro-wheals we talked about,
Right.
but they offer a highly predictable, non-destructive pathway to regeneration. You are depositing the raw materials directly into the tissue rather than burning the tissue and hoping it has enough metabolic reserve left to heal itself.
Biorevitalization works synergistically with the body's existing, albeit dormant, regenerative pathways, whereas ablative therapies demand the body overcome a newly inflicted trauma.
And in atrophic patients, the latter is simply proving too unpredictable.
It is.
It is a remarkable evolution in medical science. I mean, we are rapidly transitioning away from an era where women were quietly expected to just endure the profound physical degradation of menopause.
Or rely on temporary, ineffective lubricants.
Exactly. The fact that clinicians can now utilize highly engineered polymer networks, DNA fractions, and specific amino acid profiles to functionally rebuild the architectural integrity of the vaginal wall, it's life-changing for the patients who have access to it.
We finally have the biochemical tools to address the structural root cause of the atrophy without relying on systemic hormones. It offers a profound restoration of both tissue function and daily quality of life.
And while the underlying science is undeniably incredible, the integration of these therapies into mainstream medicine introduces a fascinating sociological tension.
It really does.
As we watch these specific techniques and materials, literally the exact same injectables used to smooth wrinkles and plump skin cross over from the realm of aesthetic dermatology into essential, functional gynecological care, it forces us to examine the language we use.
Yes. The clinical literature and the industry surrounding it continually refer to these functional treatments as vaginal rejuvenation.
Right. Bringing cutting-edge science to postmenopausal women has the power to finally eradicate the deep societal taboos surrounding women's sexual health and aging. It legitimizes their physical pain and offers a real cure.
But there's a flip side to consider. When we package functional restorative healthcare under the banner of rejuvenation, we have to ask a critical question.
What is that?
Are we simply curing a physiological disease? Or are we inadvertently utilizing medical science to expand the pressure to remain looking young into the most hidden aspects of female anatomy? It is a complex line between restoring essential biological function and subtly enforcing a brand new, completely unnecessary standard of aesthetic beauty for the aging body.
That is definitely something to mull over the next time you see a high-end serum boasting about the plumping power of hyaluronic acid.